Hi, everybody. Welcome back to Dr. B Addiction Recovery. As most of you know, this channel is about all things substance abuse. And in that context, we try to take the scientific evidence, which we call evidence based medicine, we try to tie that up to clinical experience, marry the two, and digest it for you in a way that is comprehensible and easy to understand with the aim of trying to clarify any myths or mystery about substance abuse. We are aimed at the substance abuse community. In addition, for the loved ones and hopefully the general public at large and policymakers, so we can have better treatment and understanding of this treatable disease. Today, I want to take a little break from some of the other things that we've been doing on this channel and go back on opiate use disorder, and in particular, the thought and concept, give you some thoughts and the concept of medication assisted treatment and Suboxone, which we're going to use the term buprenorphine from now on because that is the active ingredient. And the topic that keeps coming up on a lot of social media and people keep asking is a lot of criticism against medication assisted treatment, whether it's replacing one addiction for the other, or the withdrawals are worse than this than heroin. A whole host of complaints, criticisms, and sort of attitudes towards medication assisted treatment that I think underlying all of it is a lot of misunderstanding and misuse of the medication. I can go through different kinds of criticisms that are asked, but I thought it would be better to sort of classify these into three different areas and try to capture as much as I can in each area in a short video. Why does buprenorphine medication assisted treatment or Suboxone fail? And I classified it as into three areas that you can look at. And those three areas would be: one, from the patient side; two, from the provider side; and three, institutional slash cultural. In addition, these are not distinct areas and it's not all encompassing in answering all of the questions. The areas are all related and feed into each other, and it's sort of this sort of entangled web of a feedback loop that it's negative and it causes failure. The first area is going to be under the patients, and keep in mind these aren't distinct areas from patient to provider to institutional cultural. Two, it's not meant to capture every reason, and three, you have to take it for what it is, general descriptive analysis, and it may not apply to particular individuals. But under patient area, I have three distinct kind of areas that lend into each other. One of those I label as self-management, okay? The second area I label as underdose, okay? And the third area I label as tapering, too fast or too early, okay? Let's start off with the first one, self-management, okay? I see a lot of patients, whether my patients or people I speak to, substance abuse patients, or a lot of feedback on the social media channels about people describing something, and either they're specifically describing it or it just smells like the situation where there's a lot of self-management going on. And what do I mean by that? What I mean by that, how do you end up self-managing? When you see a physician and you're thinking a physician gives you a prescription, and you take that prescription and you just keep taking it and you change directions as the clinician advises. And this is where the areas sort of overlap because they're all related to each other. It's not that simple. Number one, this is medication that is obtained illicitly on the streets or from friends, or people may have some left over. There's enough of a supply out there, and there's enough deviant behavior surrounding this issue where there's a lot of self-management. And people might decide on their doses, they might decide on how to take it, okay? And they might decide when to stop. And all of this can lead to treatment failure. At the most basic level, if you, the individual, is not given the proper dose and the proper frequency, and you are not being evaluated on a regular basis by somebody, there's a good chance of failure. Okay? So I'll be talking to a patient and they may be obtaining their medication on the street, okay? Or from a friend, or they were just in jail. And it's like, and they describe to you how they take it or when they take it, and they may say something to you, oh yeah, I take 2 in the morning and then I start to feel withdrawals at midnight and I'll take another one, okay? That is absolutely the wrong way to take it, all right? Or they might tell you, yeah, I'll take it and try and go as many days as I can, and then if I can't take it anymore, I'll take it again. That's absolutely the wrong way to take it. Or they'll say, yeah, I try to keep it down to, for example, 4 milligrams a day. Okay, I really try to keep it low because I don't want to get another addiction. That's the wrong way to take it. Or they might tell you, yeah, I want to keep it low, and I am kind of taking a whole bunch of Valium or Xanax, or even they end up increasing their meth intake or stimulant intake because their goal is to get off of this stuff as soon as possible. That's the wrong way to take it. Or they might approach this whole thing with the perception from friends, from society, from family, even from their physicians. And as I said, the areas are interrelated, where the goal of this stuff is to be on it as short a length of time as possible. Well, that's the wrong way to look at it. There are many more examples, and as I said, they're all within the big, broad categories of patients, providers, institutional, cultural. They all lend to each other, and these create an environment where wrong perception, wrong dosing, wrong frequency, even the wrong way of taking it mechanically kind of transpires into the patient's approach into this medication, and they fail. Okay. The second area under the patient is the underdosing, right, which I've already described, which they take as little as possible, or they just don't understand how they're supposed to take it, and they're going through cravings and some sort of withdrawal all day. The medication is supposed to be taken to clinical effect, no cravings, no withdrawals over a 24-hour period, and this causes potentially can cause relapse. And finally, the third area under patient, which I did touch on, is for whatever reason they decide, and their doctor may go with it, or he may even advocate it, or he may not even really understand what you're supposed to do here. They taper off of this medication way too rapidly, a week, 2 weeks, a month, depends on the patient. But it's way too rapid for them. And it's also way too early for where they are at in terms of their substance abuse. And in these areas, and when they do this, then they get the impression that, wow, this stuff is harder to kick than heroin or methadone, and the data doesn't show this at all. And they also relapse. So under patient issues, there's these 3 different kind of subcategories of self-management, too fast and too early of a taper, in addition to general underdosing of the medication. And all of those sort of contribute to potential patient failure. And now they're sort of even deep further down that fictitious paradigm and perception of what this medication is and what it does. I want to add one more little area that kind of is associated for all of those. Most of the time, most people that I talk to, even many providers, have an incorrect understanding of the mechanism of this medication, the difference between different formulations such as Suboxone, Subutex, buprenorphine, how the naloxone works, and all of this also lends to potential treatment failure, and it stigmatizes medication assisted treatment even further. The second large category that I want to put into here after patients is the provider. Now, in no way am I coming down on providers that are trying to do a good job and provide this stuff, but this is just some of the issues that come up, and maybe we all need in general a little further training and edification on this medication. But sometimes it's not that because, as I said, every large area here, patient, provider, institutional, cultural, they're all kind of lending to each other and feeding off of each other. So under provider, one of the areas is that the provider themselves stigmatize this medication, and this is going to cause an emotional bias towards what you should look at objectively with validated data, and then make the best clinical judgment you can. So maybe some of the providers with their own personal biases towards medication assisted treatment infuse that and lend that into their clinical discussion with the patient on this medication. And that could be disastrous, and I see that often. That's number one. Number two is potentially providers' approach to this medication. Now, one of the problems we have, and again, this lends itself from social, cultural, institutional, is providers nowadays don't have that kind of time where they should really be doing what we're entrusted to do, and it is not their fault. It is what it is. This is not a medication you just give someone a prescription and tell them to take it with a few special instructions. Okay, it's important to thoroughly educate the patient, especially when you're first establishing clinical rapport. Number two, you have to continuously, especially after initial and early induction, not the technical term induction, but just starting this medication and getting to know the patient, you have to have close follow-up with this patient so you can grossly and micro adjust the dosing, okay, to get the best clinical effect and outcome. And oftentimes this is difficult for providers, or they might not have enough education and training on this issue. Number three, because of provider busy schedules or maybe their own lack of training, there has to be education, re-education, emotional and clinical support for the patient on this medication. And I think sometimes that's not being done, okay? And the level and intensity of education and care you give the patient should really depend on where they are at in their recovery, whether they're very early, which you can manage a lot of patients that nowadays go to detox at a cost of thousands, sometimes hundreds of thousands. You can manage them as an outpatient clinic if you just could take the time to do that extra bit. I understand from the provider side because sometimes, the compensation and payments just isn't enough for them to be able to provide that service completely. And this is not a knock on them or a judgment on the provider, because in truth, these providers also have to survive, right? And some of them are doing the best that they possibly can. So there's a lot of issues on the provider side that could cause treatment failure. Again, lack of understanding of the medication itself, micro adjusting, education provided for the patient, and appropriate follow-up depending on the stage of when the patient is taking this medication, and their own cultural, social, moral, ethical biases that might get in the way of correct dosing and figuring out when the patient has to come off of this medication. So that's on the provider side, and as you could see, that will lend itself also to the patient making autonomous decisions when they really shouldn't be, and they should sit aside for a while and let the provider drive the bus and guide them. It also it's also sort of infused with the institutional cultural attitudes, whether it's towards our sort of political economy and the pay structure, or now we can move really into the third category, institutional cultural. I'm going to say ours does not support medication-assisted treatment and a sober-minded approach to substance abuse versus oftentimes judgment and punishment. Okay, our institutions, whether it's our, I think, healthcare institutions, or our legal system, or our oftentimes our policing, and certainly our incarceration system, it's sort of set up with in terms of this issue and many other issues in this issue, where it does not support the proper dispensement and management of what we can call, again, medication-assisted treatment. Okay? Again, there is inherent, implicit, and explicit institutional biases that dribbles down into the individual providers and policymakers, that actually dribbles down into the family and friends of the substance abuse patient, that actually dribbles down into the views and the perceptions of the patient. So you see all of these things sort of lend to each other, okay? These cultural, institutional attitudes, some of them come from the 12-step tradition and our views on how substance abuse should be taken care of and what is considered addiction versus treatment. And that is all from the institutional cultural side. And this also includes access to care for the substance abuse client, access to quality scientific evidence-based care for the substance abuse client, institutions being geared towards punishment versus rehabilitation that lends itself to treatment failure. So we have three broad categories, and I see them and feel them daily, whether it's through criticisms, whether it's on social media or patients themselves. I do not want to be on this stuff. I don't want to trade one addiction for another. The withdrawals are the worst thing ever. And when you make when you make a comment like that to me, I have a question for you. Okay, who took you off of this medication? At what point in your addiction were you taken off this medication? What were your signs and symptoms and personal psychological health, emotional health, and social health when you were taken off this medication? And how quickly did you come off this medication? And what was the dosing when you came off this medication? So all of these, again, as a group, as a whole, as a body, lend themselves to treatment failure. I hope you liked this video. If you did like this video and want to see more like it, go ahead and click on videos above to my left. And we would really appreciate it if you, down to my left as well, press the subscribe button and the notification bell. We have a lot more good videos coming. I keep promising other topics and doing series. I am doing the best I can. I hope you stay safe out there during COVID. Seek treatment, and if you fail, seek it again. We are here for you. See you next time, and thank you very much for watching.